Hello and welcome to the third event of BMJ India webinar series. I am Sheetal Mattu Kaushik from the marketing team of BMJ India. This program is an educational initiative by BMJ with the aim to move towards a step towards our vision of creating a healthier world. Through these webinar series, we bring new and relevant topics each month, which will be delivered by different senior clinical experts from India to share latest updates and practical tips while managing patients. We hope these series of webinars will create a positive impact on your clinical practice. We are thankful to Tata 1MG Labs, who is our title sponsor for the series. Now, before we start, there are a couple of quick announcements to make. You can watch the live streaming in full screen mode, and you can also post your questions related to the topic in the chat box provided on your screen. The speaker will try to answer as many questions as possible in the limited time period that we have. You can also download the certificate at the end of the webinar through the links provided on your screen. We bring new series each month. So to get updates on the next webinar, follow us on BMJ India at LinkedIn and on Facebook. We are also happy to announce that the participants will receive Tata 1MG Labs discount coupons through emails post the webinar, which can be extended to your patients. I would now like to call upon Dr. Simi Kaul, who is our clinical editor at BMJ, who has got more than 15 years of rich experience in the publishing industry, to take over from here. Dr. Simi.
Thank you, Sheetal. Good afternoon, everyone, and a very warm welcome to all the participants. We are delighted to present to you BMJ India webinar series, which aims to bring to you the latest evidence-based clinical updates from expert speakers. It is specially designed to help you improve patient outcomes in your daily practice. And now, coming on to today's topic, management of type 2 diabetes mellitus. Reduction in hyperglycemia primarily focus on increasing insulin availability. It can be either through direct insulin administration or through agents that promote insulin secretion. Improving sensitivity to insulin or decreasing the absorption of carbohydrates from GI tract. Increasing urinary glucose excretion. And today we are going to discuss all of these in detail. Let's get started and welcome our speaker for today, Dr. Nikhil Tandon, eminent endocrinologist, professor, head, Department of Endocrinology and Metabolism, All India Institute of Medical Sciences, New Delhi. Over to you, sir.
Thank you, Dr. Kaul. I just want a confirmation from you that my slides are visible.
Yes. Perfect.
And in the mode that we want to see them.
Yes.
Well, good afternoon to everybody, and I'd like to start by thanking BMJ for putting together this webinar series. And it's a pleasure for me to be part of this, and I hope that this will be an interesting, informative, and interactive afternoon. And I will now proceed without spending too much more time, except to say that while the focus will be on oral anti-hyperglycemic agents, I will briefly allude to insulin as we go along, because even with type 2 diabetes, there is a requirement for insulin, especially late in the course of disease. I have no conflicts of interest to declare. The learning objectives of today afternoon are who and how to screen for diabetes, identify the categories of dysglycemia, management goals and targets, components of management, then the pharmacological therapy, and we'll wind this up by formulating an individualized plan for diabetes management. Right. So when to screen? Traditionally, the age for screening has varied over a period of time, depending on the age at which type 2 diabetes really has started manifesting in the community. Today, we say that anybody above 30 years of age should be screened. In fact, the government of India has, through the National Program for Prevention and Control of Diabetes, CVD, Stroke, offered universal screening for 5 non-communicable diseases: diabetes, hypertension, and 3 cancers: breast and cervix in women, and an oral cavity in everybody. everybody over the age of 30 years. However, you can actually even take the screening age lower down in the case that there are certain special risk factors. A family history of diabetes, being overweight or obese, having regional adiposity in the form of an abdominal circumference which is elevated, hypertension, dyslipidemia, presence of heart disease or cerebrovascular disease, a history of gestational diabetes, which is very important because we often forget that post-delivery in a woman with gestational diabetes, they must be screened and screened periodically. And of course, the polycystic ovarian syndrome, which is, again, something associated. Now, none of these things written are really causal, but they are significant associated risk factors for diabetes. And the reason why 30 is a good number is if you look at these data from the ICMR INDIAB study, and you're looking at the prevalence of diabetes, and we won't, without concentrating on whether it's men or women or urban or rural, you'll see the inflection point at which suddenly the number of people with diabetes starts to rise is somewhere between 25 and 35. So 30 is a good number to actually put an universal screening. How should we screen? Fasting venous plasma glucose, an oral glucose tolerance test, a random venous plasma glucose, or glycosylated hemoglobin are the different things which have been recognized, and there are different diagnostic criteria for that. But before we talk about what is abnormal, it's important for us to decide what is normal. So a fasting venous plasma glucose of less than 110, this is what is recommended by the WHO, and this is what is endorsed by the ICMR. If you were in the US, it would have been less than 100 milligram per deciliter. A 2-hour post 75-gram glucose, venous plasma glucose. So it is not capillary blood glucose, it is venous plasma glucose of less than 140 milligrams per deciliter. A random venous plasma glucose, which we equate with a post-load value of less than 140, and a hemoglobin A1C done by a method which has been a part of the National Glycohemoglobin Standardization Program, which relates back to the DCCT study of less than 5.7%. Intermediate hyperglycemia. Now, this is a term which is increasingly becoming the preferred term as opposed to pre-diabetes. Why I say this is because when you use the word pre-diabetes, it sort of gives the impression that there is an inevitability that this person will progress from pre-diabetes to diabetes, whereas intermediate hyperglycemia clearly indicates that this is a halfway house, neither normal nor abnormal, but somewhere in between. And of course, different populations, if left unintervened, can progress to diabetes from this stage. So there are two basic categories: impaired fasting glucose and impaired glucose tolerance. For impaired fasting glucose, you need to show a value of fasting plasma glucose between 110 and 125, and a 2-hour plasma glucose of less than 140, right? As opposed to that, impaired glucose tolerance requires a normal fasting plasma glucose, but a 2 hours post-load plasma glucose between 140 and 199. And of course, people can have both an IFG and an IGT, which is shown in the extreme right column. The ADA recommends a range of A1Cs which can be used to define what they call pre-diabetes, which is 5.7% to 6.4%. The WHO till now has not been terribly enthusiastic to use an A1C range for diagnosis of intermediate hyperglycemia. They're happy for A1C to be used to diagnose diabetes, but not the halfway situation. Diabetes mellitus is diagnosed based on a fasting plasma glucose of more than equal to 126. So 126 is abnormal, or a 2-hour post 75-gram glucose venous glucose value of more than equal to 200, which is also the cutoff for random glucose. And as I said, there is a consensus about an A1C value of 6.5% or more for the diagnosis of A1C. In asymptomatic individuals, diabetes can be diagnosed using any of these criteria, and but should be reconfirmed with another test. I think I'm getting a little bit of disturbance, so perhaps the others can mute their microphones. Thank you. Now, what are the practical challenges? Well, you know, in smaller places and patients often not being very enthusiastic about a syringe needle being put into their veins, you can use capillary blood glucose. Now, the only thing we must remember is that the cut points change slightly. If you're using a capillary blood glucose in the fasting state, the numbers remain the same, 110 to 125 for impaired fasting glucose and 126 and above for diabetes. In contrast, the postprandial state, the capillary glucose gives a slightly higher value, and we therefore need an upward adjustment of the cutoff, right? So instead of 200 milligrams per deciliter for the diagnosis of diabetes, it becomes 220. And instead of 140 milligrams per deciliter for the diagnosis of impaired glucose tolerance, it becomes 160. The 75-gram GTT is not a very favored. It's obviously more robust, but it's challenging. But I think if anybody has an impaired fasting glucose, it may be advisable to recommend a GTT to see a post-load value in them. And of course, in pregnancy now, it is recommended that people should undergo an OGTT at the point of first contact, some level of glucose assessment, and a GTT once during pregnancy. The other thing is, remember that the GTT was supposed to be done with anhydrous glucose, which is usually not available. And therefore, what is available over the counter is glucose monohydrate. And instead of 75 grams of glucose there, you should take 82.5 grams, which is the equivalent of 75 grams of anhydrous glucose. And the last issue, which can sometimes be challenging, is a discrepancy in the values. You can have an A1C of 7%, which is clearly above 6.5, but a fasting of 99. So if I'm just giving you a simple example, the advisory here is repeat the abnormal value to see whether that is really abnormal or was the normal value the correct one. A large bulk of diabetes that we'll see in clinical practice is type 2 diabetes, and therefore today's talk will be on the management of type 2 diabetes. But remember, you can have type 1 diabetes, you can have LADA, which is now called a slowly progressive autoimmune diabetes, MODI, which are monogenic syndromes, fibrocalculous pancreatic diabetes, etc. You should suspect a non-type 2 variant, especially in younger ages of onset, lean BMIs, a presentation with ketosis or ketoacidosis, features of malabsorption, persistent abdominal pain, which could be a pancreatic disease, a clear family history involving 3 generations, and of course, rare endocrine syndromes, which can be associated with diabetes. What are the management goals of a person with diabetes? Number one, if they are symptomatic, you must make them symptom-free. A lot of our patients, because they've ignored the early symptoms, come with significant nocturia. So one of the earliest relief that you want to give them is not needing to wake up at night to pass urine. An improvement in quality of life, a sustainable glycemic control, and then, of course, remember, management of glucose is not the only management of type 2 diabetes. We need to manage comorbid conditions, which could be obesity, hypertension, and dyslipidemia. However, I will not be alluding to those during my talk today. I'm going to talk about glucose management. And of course, the key overarching goal is prevent vascular complications, whether micro or macro, and prevent infections. And remember, while infections can still be reversed, as of today, the microvascular or macrovascular complications are non-reversible. You may slow their progression, you may halt their progression, but as of now, we cannot reverse them. Therefore, preventing them becomes the single most important goal for managing people with diabetes. Now, when you have a person, it's important for the discussion to be had about what their target of control should be. And that's something which they should be communicated. And I often tell my patients, print this out and put them in a place where you can see it, because you need to know if you are deviating from these targets. And as you can see from this slide, we are not talking only of glucose targets out here. We talk of blood pressure, weight, waist, and lipid control also. Fasting glucose targets about 80 to 110, or people may say more than up to 80 to 120. Anything over 120 or 125 is unsatisfactory. A 2 hours post load of between 120 and 140. Anything above 180 is clearly unsatisfactory. An A1C of less than 7, but I would say with increasing availability of medicines which do not have a risk of hypoglycemia, we can actually even target for tighter control, even less than 6.5%. One of the biggest impediments to tight control was the fact that trying to achieve tight control will lead to hypoglycemia. But now with a lot of agents which don't predispose to hypoglycemia, we can be more aggressive. Unsatisfactory control if it's more than 8% or 8%. Your blood pressure target is less than 130 by 80. Anything exceeding 140/90 is not good news. BMI target of between 20 and 23. And if you're more than 25 by South Asian cut points, it is obesity. And therefore you mustn't have that. And a waist circumference of less than 90 centimeters in men and 80 centimeters in women. Triglycerides of less than 150 and an LDL of less than 100. The HDL targets, I must confess, we do indicate them, but are not usually very easy to manage in Indian people. For those of you who use a CGMS, especially for people with type 1 diabetes, I thought for the sake of completion, I would provide these data. So the CGMS gives you information of time spent in range. The range there is 70 to 180, time above range, which is more than 180, time below range, which is 54 to 69 or less than 54, and the whole issue of glycemic variability. So more than 70% time you should spend in range, less than 25% you should spend above range, and less than 5% you should spend below range, of which less than 4% is in the range of 54 to 69, and less than 1% in clearly the equivalent of 3 millimoles per liter of glucose, or 54. Shifting now to management. Now that we know what our targets are, management is lifestyle, medical nutrition therapy, and pharmacological agents, which could be oral or injectables, and injectables could be insulin or non-insulin. What are the goals of lifestyle modification? They are achieving and maintaining body weight goals, attaining individualized glycemic blood pressure and lipid goals. So an 80-year-old person with a low ejection fraction, a low left ventricular ejection fraction, and a creatinine of 2.5 will not be a candidate for tight glycemic control. A 30-year-old otherwise healthy male would be very much a candidate for an A1C of less than 6.5. Blood pressure goals again in the older person, especially if you're concerned about causing postural hypertension, so you don't want very tight control there. So remember, what we provide as an advisory must be then tailored for the person in front of you. Don't use the same pen to write the same treatment for all of your patients. And the goal, which is most important, and we must explain that to the patient, because patients are more concerned about symptoms. Whereas what you need to tell them is, we not only need to make you symptom-free, we need to make you achieve your target so that you do not have complications. In terms of strategy, we forget tobacco is still a very, very important contributor in our country to complications. We often also forget to ask about non-smoked tobacco. Oral tobacco consumption is still common in the country, and it should not be smoking cessation, but tobacco cessation. Stress management, easier said than done in our lives today. All of us are stressed all the time, but we need to do something about it. And exercise. Exercise again, and I'm not an exercise physiologist and I'm not an expert, but we often forget that we must tailor the exercise. But even before we start the exercise, we must have clarity about whether or not a particular person is suitable for a particular sort of exercise. So if you have proliferative diabetic retinopathy, doing a high impact jogging may not be a good idea at all. You may predispose to a vitreous hemorrhage or a bleed. So targets of exercise, the types of exercise, and methods become important. I already mentioned this, a pre-exercise evaluation. I'm not saying you need to do complicated investigations, but you must ask for angina or its equivalent. You must ask for exercise tolerance. And in any case, if somebody who's been sedentary all their life, suddenly telling them to start jogging is a recipe for disaster. Tell them, we eventually want you to do 45 minutes of moderate physical activity every day. But if you start with 10 minutes of mild activity to start with, we're happy. Gradually increase and reach your target. We are not planning to run a marathon, a 100-meter dash. We are planning a long-term race out here. Uncontrolled hypertension, any ECG changes must be reviewed before we recommend a person to have significant exercise. Fundus examination, very important. Vigorous intensity aerobic, and even more importantly, resistance exercise. You know, people suddenly go to the gym and you have a young trainer out there who's very enthusiastic, will say, weights kar lijiye. And then if you do a resistance exercise, in any case, we don't want heavy weights, but using a Valsalva at that point in time can actually lead to a vitreous hemorrhage in PDR and severe NPDR. Neuropathy, again, autonomic neuropathy may predispose people to problems. So again, I'm not asking you to do complicated tests, but a resting heart rate, because resting tachycardia is suggestive of autonomic neuropathy, and also static hypotension, very important. Peripheral neuropathy must be done so that you don't suddenly go and ask them to buy new shoes, tight-fitting shoes for jogging, even if they're the best company. You must look at pressure, you look at vibration, and you must look at reflexes. A high-risk foot is again a danger for physical activity. So history of prior amputation, evaluation for the presence of an ulcer, fixed foot deformity, so a sensory motor distal neuropathy causing hammer toes or claw foot, not a good person unless you get appropriate footwear. Pulses, which are diminished, and Charcot's foot, which is shown out here in the bottom right. Again, all of this needs to be evaluated, and therefore in your first evaluation of the patient, a foot examination is more important than seeing the face of the patient. Even if they're wearing a mask in today's COVID environment, that may be all right, but taking the shoes and socks off, very, very important. What are the targets? I would say, irrespective of going into meds, start slow, start short duration. You may have a target of 45 minutes or half an hour or whatever it is, but if a person has not exercised for a long, long time, let them start with a gradual exercise. Let them incorporate that exercise into their daily schedule. Achieve a minimum of 600 METs without going to metabolic equivalent. Moderate exercise, 150 minutes a week, that's 30 minutes a day, at least 5 days a week. Or vigorous exercise for the younger, more fit people without comorbidities of you can actually cut that duration down if the intensity is increased. I would say in the beginning, aerobic exercise and yoga is better. Resistance exercise can be brought in later. You do not want people to bulk up their muscles, because eventually most of them will stop exercising and the muscle is going to become too fat, and again, a problem will arise. So primarily aerobic and asana, and then resistance exercise to come in later. Medical nutrition therapy, what are our goals and what is our strategy? The first thing is, if your ideal body weight, to maintain that body weight goal. If you're overweight, to bring the weight down to what is ideal body weight, and that's pretty simple, I'll show you the formula in a minute, but in any case, it's your height in centimeters minus 102.9 or thereabouts, and you're fine with that. Achieving individualized glycemic blood pressure and lipid goals, and as always, prevention and delaying the onset of complications. A nutritional assessment, the first thing you need to do is ask the patient, take a piece of paper and write down what you usually read. It is much better to work around the patient's usual eating, if that is possible, than to bring in new items and new systems. So get a sense, modify that than to do a fresh new diet. Set goals, which can be modified with passage of time. So, saying that 25 years ago, I received 1800 calorie diet and I'm following that even today is nonsense. A diet review and advisory needs to be done periodically because it needs to be changed. Then the intervention, and then an evaluation to see about adherence and compliance to the diet. For me, without going into what is written on this slide, there are four very important parts of medical nutrition therapy. The quantity of food that you eat, the type of food that you take, how you distribute those calories. So, somebody may be taking 1800 calories, but having two large meals, versus somebody taking 1800 calories and taking three major and three minor meals. The second person is going to do that much better. And the fourth thing is spacing. So if the person takes the right quantity, the right sort of food, divides them well, but has a lot of clustering, right? Because they are, let's look at a surgeon who goes into the OT, has breakfast in the morning, comes out in the evening, and then has another 4 meals between their tea time snack and their bedtime snack, as opposed to somebody who takes breakfast, a mid-morning snack, lunch, a tea time snack, dinner, and a bedtime snack. This person is going to do much better, right? As I mentioned, the ideal body weight, so if I'm 180 centimeters, it'll be 80 into 0.9. So that's 72 kilos is my ideal body weight. And about 25 kilocalories per kg of ideal body weight is fine. And you work your way around that. I'm not going to go into this because actually diet, I don't want to trivialize diet into this, but you need to understand basic principles of diet. If you have a dietitian, great. Otherwise, you need a little bit more than a crash course. And just a single slide here would be doing disservice to the whole idea of diet. We're a carb crazy country. We love our carbs. We have a lot of that. And therefore, keeping carbs down to 55% can actually be quite difficult. But that is what you need to do. Carbs of 55 to 60%, avoid refined sugars. So I tell a person, you take an apple, which is unpeeled, you take an apple, which is peeled, and you squeeze juice out of the apple. All three instances, the amount of sugar was the same, but an unpeeled apple, the rise in sugar is going to be the slowest. In the peeled apple, it's going to be faster, and the juice is going to be the fastest. So try and retain as much fiber in the food item as possible. So if you are a person who has to have rice, please put in vegetables into the rice. Just having rice with rasam, which may not be such a good idea. Mixing rice with vegetables, both cooked and raw, is going to retard the rise in sugar after eating the same rice. If you're eating roti and you sieve the flour, there is choker which is left behind, put some of it back. So don't have refined flour rotis. So complex carbs are very important. Proteins, 12 to 15%. And with the milk, please think about low-fat milk. Fats, 20 to 30%, but definitely not more than 10% of saturated fats. The remaining should be MUFA and PUFA. And try and up your fiber content. So about 15 grams of fiber or 20 grams of fiber for every 1,000 kilocalories would be useful. Let's come to the meat of what a lot of you may be more interested in hearing. But remember, the management of diabetes needs 4 things: diet, physical activity, pharmacotherapy is only number 3, and then monitoring is number 4. So you cannot go to school in class 3, you go to school in class 1, then you go to class 2, then you go to class 3. You do diet and physical activity before you start pharmacotherapy. So we have, when I was an undergraduate, I actually took this class yesterday for my pharmacology students. So 2 consecutive days, I'm feeling I'm doing a rerun of yesterday's undergraduate lecture. In some senses, there were only 2 categories of agents which are available to me: sulfonylureas and metformin. I'm of a generation where fenformin had already started going out, so I've only ever used metformin, and then sulfonylureas, and it was glibenclamide and glipizide. Tolbutamide was going out, chlorpropamide was going out, gliclazide and glimepiride had not come in. So you can see how old I am. So now we have a whole bunch of oral agents, which could be bigonides, thiazolidinediones, sulfonylureas, DPP4 inhibitors, SGLT2 inhibitors, glinides, alpha-glucosidase inhibitors, and GLP-1-like peptide or GLP-1 receptor agonist, which now is available as an oral agent also. The injectables could be insulin, or GLP-1 receptor agonist. I think I'm going to skip this slide because this will take me too much to describe. By and large, as Dr. Simi Kaul mentioned in the introductory remarks, we have now agents which are insulin secretagogues, like sulfonylureas, like DPP-4 inhibitors, like GLP-1 receptor agonists. You have insulin sensitizers like metformin, like the glitazones, and you have glycosuric agents like SGLT2 inhibitors. So we have agents which are acting at multiple different points. My agent of choice and the first agent which we must consider in every single person with type 2 diabetes is metformin. Most people say you can go up to 2.5 grams. I normally stop at 2 grams unless it's a really big built person. Most of us have now started shifting to either an extended release or a delayed release metformin so that we can get by with 1 or 2 times daily use. The important thing I want to highlight out here is that the predominant mode of excretion is urine, and therefore there are set criteria of previously of creatinine and today of an estimated GFR, beyond which you modify the dose of metformin and then totally withhold metformin. Of the thiazolidinediones, rosiglitazone has now disappeared from because of the concerns of cardiovascular toxicity. Remember that the whole issue of cardiovascular outcome trials really came by after the ROSI issues. So pioglitazone, we used to give up to 45 milligrams. Now, because of the scare with bladder cancer, remember there was a time when there were big concerns about bladder cancer, and it is now believed that a lifetime cumulative exposure to between 28 and 32 grams of pioglitazone. So if you're taking 30 milligrams a day, right, that's a month into, so about 36 months or 3 years of pioglitazone at 30 milligrams per day is perhaps when you don't want to give beyond, you don't want to give pioglitazone beyond that. Most people nowadays use 7.5 or 15 milligrams, and in some instances when the patient has reached a stage when either it's insulin or increasing pioglitazone is when you consider pio. A small amount of it goes out of urine, the rest is feces, so you're not so concerned about the eGFR in this particular case. There's a whole bunch of sulfonylureas, but primarily it's glimepiride, gliclazide, glipizide, and glibenclamide. Glibenclamide on its own is relatively long-acting, and you can get by with 1 or 2 times a day. Glipizide needs to be given about, ideally 2, if not 3 times a day, but there are sustained release preparations. Gliclazide can be given twice if it's without a modified release, or once to twice with a modified release. And glimepiride can be given once in a day, though a lot of us, when we exceed 4 milligrams, do tend to give it in 2 divided doses, so it's not really required. As you can see, most of them are excreted predominantly through the urine. And for my practice, I don't give it once. I don't give sulfonylureas when you hit a creatinine of about 2.5. The gliptins, which are commonly used, are Sita, Vilda, Lina, Tinelli, and Saxa. At the moment, Tinelli and Vilda are off patent. Sita will go off patent by July of 2022. And then Lina and Saxa will be left, which are remain. So Sita, Vilda can be taken up to 100 milligrams a day, and the rest are about 5 milligrams. Tinelli, of course, is 20. Most of them get by with once a day. Vilda, unless extended release, was approved only in 50 milligram twice daily doses. But now you have extended release Vilda, which can also be given as 100 milligram once a day. Again, urinary excretion and therefore dose modification is required, except in the case, as you can see, of linagliptin, which goes through the enterohepatic excretion, though you don't need to modify for any degree of renal insufficiency. Therefore, it can be given even those with CKD4, and teneligliptin, which can also be given without dose modification at lower levels of eGFR. 3 of the SGLT2 inhibitors, of course, you also have remogliflozin, but the ones which are commonly used are Cana, DAPA, EMPA. DAPA has gone off patent, which makes an impact on the pocket of the patient. 10 milligrams of DAPA is a max dose, 25 milligrams of EMPA is a max dose. CANA, we usually give 100 mgs once a day. Again, because of the way they act, it is important to know that at a CKD 4 or 5, that's an EGFR of less than 30, there's not much point giving an SGLT2 inhibitors if you're looking at a glucose lowering effect. There are now studies with DAPA, CANA, EMPA, which seem to indicate that their impact on preventing worsening of renal status and their cardioprotective action may even go down to a GFR of 20. But as I said, if you're hoping for glucose lowering, then the eGFR should ideally be above 30. Alpha glucosidase inhibitors really slow the breakdown of carbohydrates and retard the rise. The common ones are acarbose, voglibose, and miglitol. The thing to remember here is acarbose is a limited renal excretion. For the others, you have to do some degree of modification, but even more importantly, they need to be given as many times as you need them with a meal. So a single tablet works with the meal it's given along with, and it should be consumed with the first bite of that meal rather than taking it before or after. The glinides are short-acting. They're also insulin secretagogues, and therefore it makes no sense to combine a sulfonylurea with a glinide. Ripaglinide is more commonly used in India. You can give 0.5 to 2 milligrams per meal, and you need to give it for each meal. It's a short-acting agent, so it's not a bad secretagogue to give. Again, in my favorite physician population, that is the surgeons. You're a traveling salesman, you go and you've got a field job, you know when you're getting breakfast, but you don't know when you're going to get lunch. Again, safer to use a glinide if you need to give a secretagogue than to give a sulfonylurea in that instance. The GLP-1 receptor agonists available in India at the moment as injectables are liraglutide, which is, well, it's actually exenatide, which is twice daily. There's a weekly exenatide equivalent, which is dulaglutide, liraglutide once a day, and now semaglutide, which is available abroad as an injectable preparation, is available as an oral preparation in India. These are GLP-1 receptor agonists. They are contraindicated with pancreatitis or structural anomalies because they've been concerned of pancreatitis and or pancreatic malignancies and medullary thyroid cancer for reasons which are not very, very clear because they can actually cause thyroid C-cell hyperplasia. You must always start at the lower dose. For liraglutide, you have 0.6 milligrams, 1.2 milligrams, 1.8 milligrams. Always start with 0.6 and bump it up every month or more to the next higher level. Dulaglutide, start with 0.75 milligrams sub-Q weekly and bump it up only after a while. And for semaglutide, which is most recently launched in the market, 3 milligrams daily for 4 weeks, then increases 7 milligrams daily for 4 weeks, and then 14 milligrams. They will cause terrible GI effects if you go directly to the large dose. And some people don't tolerate even the entry-level dose. Some people tolerate the entry-level dose, but don't tolerate the up-titrated. So if you're getting 0.6 milligrams of liraglutide and you go up to 1.2 and the patient gets very bad GI symptoms, go back to 0.6, do a re-challenge after some time, and then come back, try. If it still doesn't work, go down and stay at 0.6. What about timing of administration? Metformin, GI side effects. So in terms of efficacy, it doesn't make a difference. Before, during, after. But for tolerability, on a full stomach makes a lot of sense. For sulfonylureas, DPP-4 inhibitors, and glinides, which are all eventually causing insulin release. So either glucose-dependent insulin release, as in DPP-4 inhibitors, or glucose-independent, which are sulfonylureas and glinides, give it 30 minutes prior to the meal. SGLT2 inhibitors, give it in the morning because they also have a diuretic effect. You don't want people to be peeing and getting up at night for that. Alpha glucosidase inhibitors, not just before, but maybe at the time of the first bite, The glitazones have no restriction in timing. What about fixed dose combination? India has been the champion of fixed dose combinations, right? The advantage, of course, is reduces the pill burden. It improves compliance, better glycemic efficacy, and maybe relatively cheaper. Sometimes you find that combination with metformin are cheaper than those without metformin, and that's because of the way the drug price control, the DPCO, has been put into place. The disadvantage is dose titration is difficult. You don't want to increase the dose of both medicines, but you're compelled to do that. Combinations may affect bioavailability. A sulfonylurea metformin combination, you want to give the sulfonylurea before the meal. Patient doesn't tolerate the metformin. You give the combination after the meal. You don't want the sulfonylurea to start acting late. So I very often start with individual medicines. And once I reach a stable dose, that I try out a fixed dose combination. I don't like trying FDCs to start with. Or there's a bunch available, but it's primarily glimepiride, gliclazide, glibenclamide with metformin. And there are some triple drug combinations, and I'm not a fan of triple drug combinations. The glitazones can go with either metformin or glimepiride. The DPP-4 inhibitors are all available with metformin. The SGLT2 are available with metformin, and EMPA is also available with linagliptin. Don't combine two sulfonylureas. As I keep telling my patients, aap arhad ki dal or urad ki dal saath mein nahi khate. You never combine two dals into one meal. Don't use a sulfonylurea and glenide, so no two secretagogues together. And there is no point combining a DPP-4 inhibitor and a GLP-1 receptor agonist because they're affecting the same pathway. What about dose modification in chronic kidney disease? And this is important because, patients start having an elevated creatinine and you say, should I put them on insulin? The patient says, don't give me an injection. What can you do? Metformin, an eGFR of less than 30, not to be given. Above 60, any dose can be given. Between 30 and 60, we further divided it. So between 45 and 60, you can continue at full dose. Between 30 and 45, maximum of 1 gram. If the person is not on metformin, then the eGFR has to be at least 45 for you to initiate. Anything less than 45, do not. Thiazolidinediones don't need drug dose adjustment, but the problem is it can cause edema and worsen the CKD-associated edema. Glipizide, as I said, I can use glipizide and gliclazide, but I don't like giving it beyond a creatinine of 2.5. For the SGLT2 inhibitors, anything less than 30, you're really not going to get a good glucose lowering effect. The rest are nuances. DPP-4 inhibitors, you modify the dose for SITA. So between 30 and 50, you go down to 50 milligrams a day. Less than 30, you go to 25 milligrams a day. I'd say just shift to linagliptin or teneligliptin when the GFR is low because it doesn't need any problem. I would not, for similar reasons, give glinides less than eGFR of 30. And again, I avoid alpha-glucosidase inhibitors at less than 30. And so you do not want to give anti-hyperglycemic agents, the following anti-hyperglycemic agents during fasting: a sulfonylurea and a glenide because they're insulin secretagogues. You can give a DPP-4 inhibitor because they cause glucose-dependent insulin release. The risk of ketosis rises with SGLT2 inhibitors. They won't cause hypoglycemia. And therefore, remember, if you have a patient on an SGLT2 inhibitor who is due for surgery, it is recommended to discontinue an SGLT2 inhibitor ideally 72 hours before surgery, because if they go for a prolonged fast, especially at abdominal surgery, they may end up with ketosis. This is because of the nature of the drug itself. What are the common problems? Metformin, as I said, GI intolerance. And the two things you need to do is use an extended release preparation, give it on a full stomach, and don't start with a full dose, up titrate. Most people tolerate up to 1 gram. Then you have some people who tolerate 1.5, and then a fewer people who tolerate 2 grams. Pioglitazone can cause edema. You need to reassure people. Rarely sulfonylureas cause allergy, but they are more concerned about hypoglycemia. The problem with SGLT2 inhibitors would be genital mycotic infections. And what I tell people is every time you pass urine, please wash your perineum or your external urethra with water so that there's no caking of urine out there. If there is still mild candidiasis, you can try and treat it once. But if there's recurrent genital mycotic infections or recurrent UTI, stop it. GI intolerance can happen with DPP-4 inhibitors. So gradual drug escalation in some, very rarely pemphigoid can happen with DPP-4 inhibitors. Alpha glucosidase inhibitors, especially if you've got a lot of carbs, can cause flatulence. And with GLP-1 receptor agonists, definitely GI intolerance is a big, and therefore always start at the lowest dose and take your time while up titrating these medicines. I'm actually very mindful of the time, and I think I'll be left without time to answer questions. So I'm going to, after having said I'm going to talk to you about insulins, I apologize, but I'm going to skip my 5 slides on insulin and shift to the issue of individualizing metabolic targets, right? So the targets for therapy are not fixed. I told you right at the very beginning that you need to individualize therapy. And this slide essentially takes you through the 5 or 6 important things we must consider while taking individualization decisions. Let's start with the one on top. If somebody has, what is the risk of what is the likely impact if somebody has hypoglycemia, right? So in an elderly person, I'm more worried of hypo because they might suddenly have instability, fall, and break a hip. And therefore, I will avoid anything which is likely to cause hypoglycemia till the later. So metformin, DPP-4 inhibitors, SGLT2 inhibitors, and alpha glucosidase inhibitors are the 4 groups of agents which are not likely to cause significant hypoglycemia. The longer the disease duration, the more likely of known or unknown comorbidities. Again, life expectancy must, if there's a longer life expectancy, be aggressive. If there's a shorter life expectancy, you don't want to target 6.5%. If somebody is 85 years of age, 8% A1Cs might do just fine. Comorbidities, the more the comorbidities, please be less aggressive. Established vascular complications, I think you need to be in consultation with other specialties and decide, because a person with non-intervened coronary artery disease, for example, you cause a hypoglycemia, they go into vasospasm, you may actually precipitate angina or even precipitate NMI. Patient preference is very important, right? You must explain things to the patient and they can then decide. And of course, resources. I come from a public sector hospital. A lot of my patients will not afford 40 rupees for a tablet. And I have to be mindful of that. And that has to be discussed very carefully with the patient. So drug efficacy, hypoglycemia risk, cost, patient preference, comorbidities, and weight. So if somebody is concerned about weight gain, then the glitazones and secretagogues may actually cause worsening of weight gain, right? So again, all of this has to be factored through and discussed. Let's take you through, and I know looking at the slide will make a lot of you very unhappy. It's a busy slide, but I think it's important for us to understand this. Efficacy, hypoglycemia, weight, CV effects, oral versus injectable, and cost. So of the injectable, obviously insulin and a bunch of GLP-1 receptors, the rest are all oral. And of the cost, SGLT2 inhibitors at the moment, except for DAPA, which is off patent, all the GLP-1 receptor agonists are expensive. Insulin obviously is expensive, varying from conventional insulins to designer insulins. They will have varying, but remember there are other reasons too also, because you need monitoring equipment, you need syringes, needles, etc. I'm a big fan of metformin, and therefore metformin, SUs, TZDs, insulin, and GLP-1 receptor are the highest efficacy. Glinides, which are not here, are actually not very efficacious. DPP-4 inhibitors actually in the global data cause an A1C reduction of 0.6%, but in Indian studies, nearly 1%. So they're not as intermediate as one would have thought. And SGLT2 inhibitors vary from intermediate to high. As I mentioned, the hypoglycemia issues with sulfonylurea with insulin. The rest are safely off. Again, weight gain concern with secretagogues, but not with the ones which cause glucose-dependent insulin release, which are DPP-4 inhibitors. And of course, the most weight gain can happen with insulin. CV benefits have been demonstrated with metformin in the UK-PDS, in a whole bunch of CV outcome studies, except SAXA, which actually showed a higher hospitalization with congestive heart failure. TZDs, of course, the concern has been congestive heart failure, and the rest are either neutral or potential benefit. And the rest I took care of the oral and cost before that. So again, you need to get a sense of this while taking a decision. So for me, first line agent, metformin, longest 50, 60 years of it, robust data, no hypos, weight neutral, CV safe, low cost. The GI side effects can be difficult. Just this morning, I had a patient who didn't tolerate a gram, didn't tolerate half a gram, and I said, well, we can't use it. More than 3 years of use is sometimes associated with vitamin B12 deficiencies. One has to watch out. The other thing which we often forget to tell the patient is a lot of the extended release preparations have a dummy capsule. So, they often say, doc, what sort of medicine have you given to me that it passes out in the stool undigested? Well, it's undigested ghost capsule, but the agent has actually come through, so that's not a concern. We already talked about the contraindications of a CKD of less, EGFR less than 30, decompensated chronic liver disease, cardiac failure, and any other cause for hypoxia. Okay, what about the next line? Once you started metformin, in my practice, because of cost, I often give as sulfonylureas, right? But in reality, you're much better off looking at either DPP-4 inhibitors or SGLT2 inhibitors, because they have been now shown to be CV beneficial, retard progression of renal dysfunction with SGLT2 inhibitors. They can be weight neutral or even weight reducing, and they don't cause hypoglycemia. Congestive heart failure, so the cardiologists are now very keen to give SGLT2 inhibitors. And as I said, for CKD, SGLT2 inhibitors and linartineligliptin if it's low. Each of this additional agent will drop your A1C about 1%. When will you initiate insulin therapy? If there is ongoing weight gain and A1C despite at least 2 or 3 agents with a 9%, fastings of more than 270 and a random of more 300 with medication, and failure to achieve a target A1C with an optimal dose of 3 agents is clearly something. Every emergency, every intercurrent illness, all acute issues, safer to temporarily put people on insulin and then shift back later. So that's your overall chart. Lifestyle modification for all, symptomatic with osmotic symptoms, consider insulin till you make them asymptomatic. An A1C of less than 9%, single therapy. 9% of, if it's symptomatic insulin, asymptomatic, you start with dual therapy. And then, of course, you keep up titrating. And I already mentioned to you what sort of agent choice you will make to add, whether it's an SU, which I do, because they're actually pretty good agents, as long as your patient doesn't have a significant hypo risk, or DPP or SGLT. And then, of course, you have the other agents. Add insulin in terms of triple therapy, and you're more than 1% above target. Each additional agent is unlikely to lower the A1C by more than 1%. It's usually about 0.6, 0.7% after you've given 2 oral agents. What about monitoring and follow-up? I would do one stable, a 3 monthly A1C and a fasting PP, weight and waist circumference with clinic visits, annual creatinine, urinary albumin creatinine ratio, lipids. I use self-monitoring with glucometers on OHA only in unstable disease intercurrent infections. But everybody on insulin needs self-monitoring of blood glucose. So I'm going to stop here, and I must apologize. I was instructed to take you through things in 40 minutes. I've obviously exceeded that time. But let me wind this up with take-home messages that it is not glucocentric management. You need a holistic approach to achieve all components of metabolic and vascular health, lifestyle intervention, medical nutrition therapy, pharmacotherapy, and monitoring. Metformin is my poster boy as agent number one. And then, as I said, depending on the situation, weight, hyper-risk, comorbidities, purse preferences, and patient preferences, you will decide a second agent. And with that, I'll come to an end of the formal presentation. Thank you so much. Apologies for a longer than expected talk. Happy to take any questions.
Thank you, sir. Thank you. It was very informative. I think words we have exceeded some time, but still we have time to take the questions. You have stopped on metformin, and there are a lot of questions on metformin. I understand from the presentation you have mentioned about the GI intolerance, but there is a question that is there metformin also cause abnormal LFT? The question is from West Bengal. Dr. Sen has asked.
Right. So it doesn't cause, but decompensated chronic liver disease is a contraindication.
Understood. So there is no problem as such when we are giving metformin, but then yes, there is a contraindication. If there is a normal LFT.
You're not, so you are not advised to monitor with liver function tests when you give metformin. However, if there's a person with a known chronic liver disease which is decompensating, you don't give metformin.
Okay, absolutely fine. So now let's get started. We have a question. So you have mentioned about pre-diabetes, or we say intermediate hyperglycemia, and the HbA1c level you have mentioned about 5.7 to 6.4. So we have a question from Dr. Rajendra Gupta. He said a middle-aged, non-obese patient is able to maintain HbA1c between 6 to 6.5. In this, only with lifestyle modification. In this case, should OHAs be started?
So at the moment, professional association recommendations is that there is no indication to start an OHA. You can continue with lifestyle as long as they are maintaining. There is no recommendation. I mean, people give OHAs, but if you're asking for a recommendation, there is no recommendation.
So next question, Dr. Bera, he's interested to know how to manage patients who are suffering from diabetes and induced hypertension with high serum creatinine levels.
So I think there are two parts to that. One is the management of hyperglycemia in a person with elevated creatinine, and then there's the management of hypertension in a person with elevated creatinine. So let me answer the first one first. I think some of this would have been covered in the talk in any case. An EGFR of less than 30, not a good, you don't give anybody metformin. Between 30 and 45, if they're not on metformin, you don't start metformin. If they're already on metformin, anything above an EGFR of 60, any dose between 45 and 60, any dose between 30 and 45, half max, which is 1 gram as far as I'm concerned. I give a sulfonylurea till a creatinine of about 2.5. I give linagliptin or teneligliptin at any creatinine level. I give an SGLT2 inhibitor at an EGFR of 30 or more, because I don't expect them to cause glucose lowering below that. I give a repagninide at an EGFR of more than 30. So you have these groups, but you need to really monitor. Honestly, if it's a long-standing diabetes going to diabetic kidney disease, invariably you will then also start thinking of injectables. In terms of blood pressure management, I won't go into detail because that's not the topic for today. But ACE and ARBs are still agents of choice. Remembering, however, the people get a bit panicky that their creatinine was 2.5. I gave telmisartan, it became 3. Don't worry. You have to be more worried about potassium, rather than creatinine. If your potassium exceeds 5.5, look at other contributing factors. If you can bring it down to below 5.5, you can actually continue. Every time you up titrate a dose of an ARB, a week later, you must do a potassium, because potassium is what's going to cause more problem. A mild increase in creatinine is not something which you should be worried about. Doubling of creatinine, yes, you should be worried about, but a mild increase in creatinine, you shouldn't worry
about. Thank you. We have next question from Nepal. Dr. Pradhan has asked, his question, metformin is causing weight loss. Any alternative to it? He takes metformin 500 mg PD with sitagliptin 50 mg since last 9 months.
So, but most people want weight loss, right? So most people don't complain about weight loss. Metformin doesn't really cause significant weight loss unless there is a GI intolerance, right? So again, if you're losing weight because of metformin and you don't want to lose weight, then you need to stop metformin and look at one of the other options. DPP-4 inhibitors are usually weight neutral. SGLT2 inhibitors can cause some degree of weight loss. Sulfonylureas will not cause weight loss. They'll be either weight neutral or cause weight gain. So again, this has to be kept in mind while deciding therapy.
Continuing with metformin, Dr. Soni has asked, is there any role of metformin in type 1 diabetes?
No. Unless, okay, let me qualify. Unless you have, so you actually nowadays see people who are obese type 1, right? So they have type 1 and they have a strong family history of type 2 diabetes. You know, normally we always saw lean type 1s, but we're starting seeing people of type 1 who are obese and have features of insulin resistance like acanthosis. We try metformin there to alleviate that insulin resistance, but that's, again, it's an off-label recommendation. It's not a regulated approved.
We have 2 questions which I am trying to merge, and it is especially on lean body. So there's a question from Dr. Shibin and Dr. Satinder Singh, and the question is, why does a lot of young people around 30 years of age, lean, hardworking manual laborers, develop diabetes, and increasingly, it is increasing in number in recent years? What is the reason? Is it Asian phenotype, westernized lifestyle, which we are following, greater awareness, or availability of new advanced medical services which are available to us?
So I think he answered the question very well himself. There are possibly multiple, but remember, so the belief that insulin resistance is the dominant cause for progression to diabetes is increasingly being challenged. Declining beta cell function is important, and there are now what are called cluster analyses from all over the world, but a couple of them from India, which has seen that if you take recent onset type 2 diabetes in a significant proportion, 30-40%, you'll get features which are consistent with sort of insulin deficiency or a beta cell dysfunction rather than a dominant insulin resistance. So there is a declining beta cell function which is contributing to development, and that could be seen in people who are lean. It's like LADA. LADA traditionally, within a year or so of starting OHA, people who are in control in OHA start requiring insulin. So there are a component of declining beta cell function which could be related to the leanness in the phenotype of people with type 2 diabetes.
Do I know the answer? But still, I would like to ask. So the question has come from Dr. Deepak Yadav. What is the drug of choice in low health care settings in rural communities?
Metformin 1, Metformin 2, Metformin 3, Metformin 4, Metformin 5.
Perfect. I knew the answer, but I wanted to ask. Okay, so last question. I think we have exceeded the time. So last question from Dr. Rekha. 70 years female coming with first time reading of HbA1c of 12. Lean patient, 37 years female patient, was routinely asked for HbA1c while treating COVID in January with first time reading of HbA1c as 12.5. Averagely filled, no comorbid condition. How to approach this patient?
So short answer is this person has to be on insulin, right? for the reason that even if she responds to OHA is going to take a long time. There's significant glucotoxicity, which is going to impact on recovery of pancreatic function. I would treat this person on insulin, normalize their glucose, then reassess their response to oral agents, but must start that person on insulin straight away.
Thank you so much. With this, we come to an end. I think it was an excellent and wonderful session, equally informative Q&A. And I'm sure our participants have enjoyed as much as I have listening to it. And for the people who might be having some trouble with the audio quality, we would be we are recording this session, and we would be sharing the link with you once the event gets over. We really hope that we have met your academic expectations. Just spare 30 minutes to share your feedback with us. Thank you. You were the excellent participants. And thank you so much for taking out time from your busy schedule and join us for the webinar. This brings us to the end of today's webinar. And before we conclude, we'd like to announce that there's a next month's webinar, which is scheduled for 29th of April. And the topic is anxiety and depression in primary care. So before you log out, refresh your page to download the certificate, which is reflecting on your screen. And thank you so much. Till we meet again, stay safe and take care of yourself. Have a wonderful day. Thank you so much.
Thank you. Bye-bye.